And so without much further, I do want to introduce our keynote speaker. Dr. Keith Chen is Professor of Behavioral Economics and Strategy at the UCLA, excuse me, UCLA Anderson School of Management. And you can read his full bio and abstract in the app or online. But however, I will mention, if you have read that, it's a really, really fascinating, is really a good word, and really unorthodox way of approaching and analyzing COVID spread among nursing homes. And, you know, we all know that over the past 2 years, that was an extremely vulnerable population. And just as a way to really look at that and sort of, you know, I hate to use a catchphrase, but really get outside the box and look at some of that stuff using a ubiquitous piece of technology that we all have and a lot of times don't even think about. And it's these smartphones we carry in our pockets, and just the world of things that that data can open up for us. So without anything further, I will turn it over to Dr. Chen. Thank you very much.
Thank you very much for that introduction. I very much appreciate being here. It's a group whose work I greatly admire, and I'm thrilled to be able to kind of share what my co-authors and team and I have been working on lately. I'll jump right into it. You know, I don't think kind of, you know, a lot of what I'm going to be talking about requires a lot of motivation, but let me just kind of like start off by kind of talking about the question that many of us have been addressing, right? I mean, you know, COVID-19 has presented, you know, recently this kind of unusual confluence where, you know, like, you know, it feels like a majority of the world's researchers have been kind of tackling this, you know, essentially the same problem, although from many, many different angles. We came at this largely because, you know, early on, let me present the puzzle that kind of, you know, we were presented. Early on in the pandemic, let's, you know, think about the entire the entire 2020, 2021 experience, you know, slash kind of a resurgence much more recently. The vast majority of the, you know, I'd say like the costs and deaths of COVID-19 occurred in nursing homes. This is not really that much of a puzzle. It's a very vulnerable population. You know, that they typically present comorbidities that make them particularly kind of susceptible to this. But it is a little bit of a puzzle when you realize. So let me give you some statistics. For example, you know, my colleague Judy, you know, lived in Connecticut. You know, Connecticut was one of the first states to lock down nursing homes. You know, fortunately, because you know, nursing homes are centrally regulated. You know, CMS was able to issue guidance, you know, that relatively early on in the pandemic said, listen, you know, this is particularly vulnerable populations. You know, we're going to ask all nursing homes nationwide to basically shut down, to basically say, like, you know, we're going to provide additional PPE. We're going to provide, you know, additional, you know, nursing home workers will be some of the first in the country of and nursing home residents and workers will be some of the first in the country to have kind of vaccines available to them. But we're just going to completely shut down. You know, we're going to close nursing homes nationwide to visitors, except in extreme circumstances. And even then, like, you know, even if unfortunately, kind of you had a loved one kind of, you know, with bad health kind of conditions, oftentimes you would even in those situations, family would only be able to visit. And kind of, you know, you saw these like heartbreaking pictures of people hugging through kind of effectively shower curtains. Despite that nationwide, extremely kind of aggressive lockdown of nursing homes, COVID-19 spread in nursing homes continued to rise, if anything, and not fall. If anything, accelerated nursing homes. This provided an incredibly disproportionate burden on nursing homes. So in Connecticut, in my co-author state, in the first year of the pandemic, 72% of deaths in Connecticut occurred in nursing homes. That was you know, particularly bad state, but you know, New Hampshire, Rhode Island, and Connecticut, kind of in some sense the upper the kind of New England experienced this in particularly bad form. But within that first year, 40% of all deaths nationwide occurred in nursing homes. So the question that we were asking was, why is it that the kind of shutdown to visitation in nursing homes really seem to have a very, very minimal impact on this? Okay, and a very, very natural hypothesis, one that didn't kind of begin with us. One that was kind of, for example, highlighted by CDC kind of contact tracing that we'll talk about in a second, was that this was not community spread, right? This was not kind of because of the lockdown. This was not community spread. This was the COVID-19 was continuing to get into nursing homes through workers, and in particular, shared staff across nursing homes appeared to emerge as a potential culprit, because nursing homes, a very, very strong predictor of which nursing home in a particular state was going to have a bad outbreak. An extremely strong predictor of that was which nursing home had a very, very bad outbreak 2 weeks ago, and which nursing homes did they share staff with. Okay. Now, the interesting thing is that despite the early contact tracing showing this as a potentially important vector for the spread of COVID, there was no administrative data being collected on this question, nor did it appear as if there was even a legal way to collect those data. So what do we mean by that? Well, what we mean by that is most nursing home operators were not required to collect, did not collect, and in fact, felt there were barriers to asking their staff, what other nursing homes do you work in? Even what other kind of medical settings do you work in? This was just simply not known. Okay, so let me take an opportunity to say a lot of this research resulted in a tool which several states in the United States and several large counties, including the county I live in, LA County, use. The address is right here, http://protectnursinghomes.org. I wanted to kind of highlight it for you. You can go here for kind of more details, and also, I'll give you a little bit of background on how we produce this work, and then you can take a look at the kind of product of it yourself up here at this protectnursinghomes.org. Okay, what are we going to do? Well, what we're going to try and do is we're going to try and use somewhat commonly commonly studied GIS data, but in a new way to try and kind of circumvent this lack of an administrative solution, and get at and to both measure a kind of shared staff network amongst nursing homes, and then two, to try and econometrically test the degree to which we can causally say, this shared staff was contributing to the spread of COVID-19, contributing to the severity of COVID-19 in nursing home cases. One, kind of, can we estimate that effect causally? And second, can we estimate kind of the counterfactual? So, for example, what if the United States had been able to radically increase the very, very high quality PPE available among nursing homes? We did early in the pandemic, we haven't. What if the United States had been able to kind of provide on-demand, very, very rapid PCR testing, kind of test to stay policies in nursing homes for nursing home staff? Several states and counties have implemented that, but it's not nationwide. Third, what if we had gone even further and done something like, for example, British Columbia in Canada, and just raised funds and said, listen, nursing home workers are very, very vulnerable. Many of them work multiple jobs precisely because of the need to make kind of living wages. They need to hold kind of part-time, and many of their shifts are part-time. They have to hold it across several settings. What if we had raised funds at the national level to simply say, listen, here's what we're going to do. Every nursing home worker has to choose a single facility. You're not going to be allowed to work across multiple facilities for the remainder of the pandemic, but we're going to be able to make up those lost wages for you. I'll give you something of a preview. Those more aggressive interventions, which were carried out, for example, in Canada, but those more aggressive interventions, we're able to estimate that would have conservatively reduced the death burden in nursing homes in the United States by over 40%. So if you think about, over 40% of deaths in the United States occurred in nursing homes, if we would have been able to reduce that 40% by 40%, we can talk about the cost effectiveness of that expenditure. It's comparable to aspirin. I mean, it's one of the most cost-effective medical interventions of all time. Okay, what are we going to do? Well, many of you probably already know, ubiquitously available is anonymized smartphone location data. So how do we think about this? Well, Google obviously knows where every user of an Android phone is at any given moment in time. Apple knows where every iOS device is at any given point in time. Many ubiquitous apps like Facebook ask for kind of the ability to kind of know your location even when backgrounded. Facebook, has a tremendous sense of this, but increasingly these data are becoming democratized. It's increasingly a large kind of monetization strategy for apps to ask, for example, your weather app, many other social apps, navigation apps often ask for the ability to know your location even when the app is backgrounded. Those data are typically more powerful when aggregated across apps because, of course, not every app is either open or backgrounded on your phone at all times. And there are several firms that have emerged that aggregate that information across different apps, clean it, and then basically provide a panel, usually depending upon how kind of consistent you need the data, about 20% of the adult American population, you have basically real-time information every 10 minutes. Really, really simple. You just know where the device is every 10 minutes. Okay, we kind of work with several providers, purchase some of that data, and we'll kind of tell you a little bit about what we're going to do. Okay, here's what we're going to do. March 13th, all right, is the date. March 13th, 2020 is the date that CMS shuts down nationwide. Okay, it's the kind of critical date that we think about because after March 13th, phones that move in and out of nursing homes quite a bit, okay, but seem to spend kind of considerable shifts of time in nursing homes are reliably, we can infer that their staff, because of course these nursing homes are shut down to visitation. Likewise, kind of, many residents of nursing homes own smartphones, but those would be smartphones that are easy to identify because they kind of never leave the nursing home post the lockdown. Let me kind of take you straight to the say like early on, kind of in King County, Washington, the site where kind of nursing homes spread, the first site in which kind of COVID spread through the United States. There was a CDC, a very, very intensive CDC kind of contact tracing operation that identified that, facility A is the kind of life care center in King County, Washington, the very first site in the United States to record kind of positive COVID-19 cases. Both patient transfer and shared healthcare workers were identified early on as kind of the way that COVID got out of that first facility and spread. Basically, all subsequent facility spread within Washington state was linked to shared staff. And then patient transfers, patient transfers were eventually shut down across these facilities. But again, like how do you trace that nationwide? Okay. A couple of interesting kind of just one more thing I'm going to say on background, which is, this is what we're going to identify here is a little bit of kind of a negative unintended consequence of what might otherwise have been, and what in other circumstances is actually a very positive law. In fact, what we discovered was the vast majority of the staff networks that were largely responsible for COVID spread occurred through temporary staffing agencies. Now, what do I mean by that? Well, in most states, okay, and in fact, to a minimum degree, many states have a standard that go beyond this, but to a minimum degree, in the United States, we have minimum staffing laws in nursing homes. And that says, listen, for every resident in a nursing home has to be able to provide at least kind of X number of contact hours with full-time staff. That typically also translates to a minimum staffing rule. Like, listen, if you have, for every X resident hours you have in your facility, you need Y kind of permanent staff, kind of staff hours in your nursing home. Okay. Now, normally this is a great idea. You think this is a very kind of salient kind of quality measure. staff have to have residents have to have contact with staff at least 3.5 hours per day, for example, in my state of California. The problem is, in order to meet that, because of natural staff fluctuations, say a staff member kind of calls in sick, you can't just shut down the entire facility because you're going to fall below this threshold. Most nursing homes in the United States were, in order to be able to meet these requirements, had to then contract with kind of staffing agencies that purposely moved temporary staff across nursing homes because of certification rules, from nursing home to nursing home. What does this mean? This means in the middle of a respiratory pandemic, exactly when some of your staff start calling in sick because there is COVID spread in your nursing home, you are required by law to bring in additional staff on a temporary basis to basically rotate through your nursing home. And then these staff often work at nursing homes that are connected to you through kind of shared use of the same temporary staffing agency. We're going to be able to talk a little bit about the degree to which those temporary staffing agencies and their shared kind of customer network are also largely responsible for what we observed. Okay. Let me just jump right in. Okay, so what are we going to do? Many of you kind of know some of the techniques that surround kind of this particular type of use of GIS, but what we're first going to do have to estimate and kind of note kind of spatial populations of interest. What we do is we say, because CMS regulates nursing homes, every nursing home in the United States, we kind of have a mailing address for. This is the nursing home that's closest to where I live. It's on, let's see, make sure it's on, I think it's on kind of Sepulveda Boulevard, very close to the UCLA campus in Los Angeles. That pin is basically the latitude and the longitude that Google Maps gives you if you put in the mailing address, the kind of legal mailing address of this nursing home. Google does a very good job of making sure that those pins typically hit a rooftop. And what we're going to do is we're going to form, using just kind of machine learning off of satellite imagery, the red geofence, which is the actual rooftop geofence, the geofence of the rooftop of that facility, and then we're going to convexify that into the yellow geofence, and we're going to use these yellow geofences, and we're basically going to ask, first of all, going back to these smartphone location data, in the 11 weeks following the lockdown. Okay, so 11 weeks following when the only phones that are supposed to be moving in and out of nursing homes, are staff. Let's find the digital signature of every smartphone that ever appears in the U.S. nursing home. Okay, we then apply several filters. We know kind of when typical staffing kind of shift changes occur, and we also going to filter out smartphones that appear to never appear not in a nursing home, that never kind of leave the nursing home. We think of those are likely resident smartphones. After subtracting those off, we get basically kind of a set of phones that we think of as kind of likely nursing home workers. Okay, and then we basically ask, what other nursing homes do we observe share kind of staffing of the same kind of smartphones that this nursing home does? Okay, what we find, okay, is that we identify about 500,000, about 500,000 smartphones that have ever visited in this 11-week period any of these nursing homes. Okay, we kind of filter that down to about 50% of that we kind of infer our staff. And what we find is that it differs a little bit state by state, but approximately somewhere between 5 and 10% of smartphones that enter one nursing home, that enter any nursing home in a particular setting, also appear to enter other nursing homes nearby. Okay, so we're going to think of that as kind of a contact pair. What does that induce? Well, that induces a very, very standard kind of network theory kind of thing, which is it allows us to measure a contact matrix. What do we think of that as a unit kind of an undirected network. What are the nodes in that network? Nursing home facilities in the United States. Edges then become, edges in this network become any two pair of nursing homes where they share kind of staff, where we infer that they share staff. In other words, at least one smartphone intensively appears in both of these facilities, typically going A, B, A, B, A, B, between nursing home A and nursing home B multiple times during this lockdown period. Okay, you can also augment the network analysis to apply weights to these edges. The most natural way that we found to do that was just say, what is the, we can apply weights to each of these edges. Instead of just being 0, 1, we could also think of them as each having a weight Wij. Wij is the number of smartphones that appear in both facilities I and J. Okay, so we can think of that as the number of shared staff between these two facilities. Okay, so let me then say, many of you who are familiar with kind of network theory are familiar with these measures, but just to kind of put us all on the same page, we can think about the degree for any particular facility. We can think about the simplest kind of network measure, degree. How many other nursing homes does this particular nursing home share staff with? Okay, so if you have a degree of 6, that's a typical degree that you'll find in many nursing homes in many states. A degree of 6 says that there are 6 other nursing homes near you with which you share at least one staff member. Okay, strength would be the total number of contacts. So with those 6 nursing homes, maybe my number of contacts is 9. If there are actually 9 workers who work in my facility who also work in some other facility, one of these 6 other facilities, okay? Weighted average network degree is take those strength of measures. If I have like 3 connections with this nursing home, what I'm going to do is I'm going to take all of the nursing homes I'm connected to, and I'm going to take their degree, and I'm going to sum up those degrees weighted by the strength of this connection. Okay, so if a nursing home has degree 5 and I'm connected with it by 3 workers, I gain 15 units in my WAND total, my weighted average network degree. And it turns out most predictive, the network feature here is, okay, we're going to get a little fancy here for a second, the principal eigenvector of that connectivity matrix. So put, every nursing home is both a row and a column, right? Nursing home I appears as row I and column I in this matrix, okay? And then just have that matrix have a bunch of 0s and 1s for any nursing home I and J. That that matrix has a 1 if they're connected and a 0 if they're not. Okay, that's like, think of that as the simplest contact matrix. Take the principal eigenvector of that matrix. The hell is an eigenvector? Maybe you guys remember from like high school or college kind of linear algebra what an eigenvector is. Intuitively, so take that principal eigenvector. Intuitively, what's neat about that principal eigenvector is it measures something very salient. What it measures is, suppose I were just to do a random walk across this contact matrix. In other words, start in some nursing home, okay? Spend 1 unit of time in that nursing home, then jump to another nursing home that is connected to this nursing home across kind of a connection link, and then just random walk across all of the nursing homes in the United States, kind of using these connections. Okay, if I were to do that, okay, the principal eigenvector, the value that this nursing home has in that principal eigenvector is basically, in the long run, how much time does that random walk spend in this nursing home? Okay, like how often does it spend time in this nursing home? And you can think of that as it's obvious why that would have kind of a very natural kind of epidemiological interpretation. If you think about that as a measure of exposure, where kind of COVID is jumping from nursing home to nursing home across these connections. Okay, let me show you kind of, and you can go up online to the tool that we put up. That tool we put up basically kind of regularly updates this connectivity matrix via kind of estimation from smartphone location data that we just talked through. Made it clear to you how we would estimate this contact matrix. And it basically, if you want to, you can put in any nursing home in the United States. And here we'll show you this graph and we'll tell you all of these statistics. This is a nursing home in Pennsylvania State. In the first year of the pandemic, it experienced 78 kind of COVID cases, and it's a degree of 10, meaning that it's connected to 10 other nursing homes. Okay, that's this, showing that as a network graph. That nursing home that we're looking at is the blue circle. Okay, the dark gray circles that you see are its neighbors. In other words, are nursing homes in Pennsylvania state that it shares at least one worker with. Okay, the size of that circle is the degree of those nursing homes. So the darker gray circles are the ones which are connected to more nursing homes themselves, which are the light gray circles, your neighbors' neighbors. Okay, and then from this matrix, from this and it can all be locally computed. From this matrix, we get this nursing home is degree 10. It has strength 10. In fact, it only shared kind of one worker with each of these 10 other things. And it has actually, because of that, a relatively low eigenvector, but because the things that it's connected to are actually, this is a relatively high eigenvector, and because the nursing homes that it's connected to are all relatively connected themselves, this nursing home is both a relatively high eigenvector and a relatively high bond measure, like weighted average network degree. Okay, things that emerge. Okay, the degree to which two nursing homes are connected, on this network is going to be highly predictive of the jump in COVID from one of these nursing homes to the other. In other words, if we see in week T, a nurse, we can't explain which nursing home becomes the first to get COVID kind of in a particular setting, but we can tell you if in week T, this nursing home gets COVID, 2 weeks from now, it's likely to be in which other nursing homes. And this is kind of interesting. So that in the upper right-hand side, you see the Life Care Center. That was the very first nursing home to record. That was actually the very first setting in the United States to record kind of COVID cases. When we looked at the next two nursing homes, and this is also what the CDC identified, when we looked at the next two nursing homes in the United States that then showed cases of COVID, it was Garden Terrace and Maryville, the kind of two nursing homes which are pictured off on the left. You could have identified that through our analysis of networks, of connected networks, because those are the two nursing homes that the Life Care Center was most strongly connected to in our kind of shared staff network. And in addition, this is something that CMS didn't actually know. When you look at their signage, you realize that they're co-owned, which is another big predictor of shared staff. Okay, so let me tell you kind of quickly ways of measuring the importance of the shared staff network. We did kind of two analyses, both of them presented in kind of a paper that's recently out in the PNAS, in the Proceedings of the National Academy of Sciences, where we kind of put the more statistical analyses of this work. Two analyses. The first is kind of cross-sectional, okay, and this basically just says in the cross-section, okay, are nursing homes that are more holding all else equal, are nursing homes that are more connected through the shared staff network. Did they over the course of the pandemic, first half of the pandemic, experience worse kind of COVID outbreaks? The answer is yes. What that most seems to load on in terms of kind of measures, if you take any of these network measures themselves, like node, degree, like we said, like just how many other nursing homes are you connected to, and eigenvector centrality, in some sense, like how central are you to this, how in an aggregate sense, how central are you to this shared staff network? Both of those highly in the cross section predict kind of this particular nursing home's like the severity of outbreaks and how often this nursing home that we're talking about is going to have outbreaks. That's highly suggestive. The other thing that we do is in several states, which before CMS mandated kind of the reporting of COVID-19 cases nationwide, 3 states, Colorado, Connecticut, and Florida, mandated that their nursing homes from very early on at the beginning of the pandemic report to the state, Connecticut, Colorado, and Florida, their COVID cases, and we were able to get that data over a much greater time span for those 3 states. And then for those 3 states, then we're actually able to do kind of more of a time series analysis. And the result of that time series analysis is very damning. Basically, okay, what you see, what that time series analysis basically tells you is that controlling for many of the things that we controlled for in the cross-sectional analysis, so we're going to have fixed effects for state, a full set of home demographics, basically kind of socioeconomic measures of a particular nursing home, fixed effects in more aggressive specifications for the tract that this nursing home is located in, local population density, local kind of population COVID-19 spread. So basically, two nursing homes that are identical on their demographics, identical on their kind of staff ratios, identical on their CMS measured quality ratings, all of these things, in identically kind of dense areas in the United States, but with different levels of connectivity. Sometimes that level of connectivity is entirely a function of your neighbors. Like, how connected are your neighbors? Like, to compare two nursing homes, both connected to three other nursing homes, but how connected are those other three nursing homes? This connectivity strongly predicts kind of the severity of your outbreak. What we find is that in the time series, in this limited number of states in which we could do the time series, very, very damning. Cases in nursing homes that you're connected to, cases in those nursing homes this week have no predictive power on your cases this week. What has predictive power is cases in these nursing homes that you're connected to 2 weeks ago, right? So that's very, very kind of powerfully suggestive that this is COVID spread through this shared staffing network, because any unobserved third causes or kind of omitted variable bias, we think shouldn't have exactly this kind of time pattern, right? But of course, COVID spread should have this time pattern, right? That it's precisely because there's an outbreak that spreads to shared staff in that other nursing home, that 2 weeks later, which accounts for a little bit of time for spread and then incubation, shows up in your nursing home. Okay. So I have a lot more that I can show you, but let me talk through a little bit of the kind of policy implications of this, and a little bit of what we've been doing with this research, and then just kind of leave time for both a break between this and the next session, and also kind of any questions. I'm happy to stick around and kind of talk with people if you have any questions about kind of any of the details around this. So what are our findings? So our findings show, a lot of the standard demographic things that have been found in the literature to predict COVID spread in nursing homes in our data also predict kind of COVID spread in nursing homes. For-profit status actually was positively associated with nursing home spread. Largely that was mediated through for-profit kind of nursing homes actually more aggressively using shared staff. Kind of being located urban, COVID spread in the community around you, African-American, all else equal, nursing homes that had a higher share of African-American residents, even holding constant socioeconomic status, appeared to have worse outbreaks. But all of these kinds of predictors were basically completely dwarfed, and many of them became statistically insignificant once we controlled for the shared staff kind of connectivity of these nursing homes. Okay. Interestingly, CMS regulatory measures. So CMS actually measured many things in nursing homes. For example, spare PPE levels, relative quality checks. CMS would sends regulators around to nursing homes, often through unannounced kind of quality checks, and they measure kind of a whole bunch of what CMS thinks of as quality measures of these kind of nursing homes. Conditional on demographics and conditional on the shared staff network, none of those CMS quality measures had any predictive power whatsoever on COVID spread. We were a little bit most surprised about this with the abundance of PPE. Unfortunately, well, first of all, early on, many of the staff didn't have training nor kind of like full kind of think of it as like N95 kind of PPE. But moreover, kind of, I think this is indicative of many of the types of interactions. It's just very, very difficult to maintain kind of COVID safety protocols when you have to kind of like lift a patient out of bed. You're straining to do so and kind of, help them go to the washroom, or, it's kind of the interactions between staff and residents in nursing homes can be relatively kind of close and intimate, and it's just very, very difficult, it turns out, to control COVID spread in those settings. Okay, both the time series and the cross-sectional analysis suggested to us the counterfactual, that if we were able to completely shut down only this channel of spread, so if we were able to, so for example, through that Canadian kind of intervention I talked about earlier, or through kind of very, very aggressive kind of vaccination of residents, to the degree that vaccination was sterilizing, we would have been able to reduce deaths in nursing homes by our kind of point estimate is 49%. And if you realize that over that basically says conservatively we would have been able to reduce the total number of deaths of Americans by about kind of 200,000 in the United States if we had been able to shut this down early. So let me say, again, I'll kind of like direct you to this kind of website. This tool that we produce, so we continue to kind of update using kind of more recent GIS data. This tool is now kind of actively used, as for example, by many different kind of states and kind of counties. Let me say in Los Angeles County, for example, the county that I live in, the kind of local epidemiological community and nursing home operators, it kind of regularly kind of use this tool. This connectivity network is the basis for the early warning system that's in place in Los Angeles County. That is to say, when first of all, many counties and many states stepped back daily testing because it just wasn't available. Daily PCR testing of workers in nursing homes, something that we did do early on in the pandemic, but Los Angeles County has kept up that daily testing of nursing home, of PCR monitoring of nursing home workers in all of the high eigenvector connectivity nursing homes in Los Angeles County. Why? Well, because that high eigenvector centrality means that these are, if you're going to see a nursing home outbreak in Los Angeles County, you will detect it earliest if you monitor carefully these nursing homes, because these are the real epicenters of the network across which the COVID-19 appeared to be spreading. And second, not only are you likely to detect COVID first if you aggressively monitor workers in these particular nursing homes, in fact, it's going to be most important from a policy perspective that you identify it early in these nursing homes, because not only are these nursing homes that you will detect COVID early in, if you detect COVID early in these nursing homes, it is likely to spread absent aggressive intervention, kind of quarantining and kind of lockdown. Sick leave precisely for the workers of these nursing homes. The early warning system then actually sends aggressive PPE, local, LA County epidemiologists and additional resources to any nursing home, and plus aggressive warnings to any nursing home that is connected to nursing homes which show an early outbreak. Using this tool in Los Angeles County. Okay, I'll stop there. I'll leave this up actually, so that if you want, you can kind of go visit and see this kind of tool yourself. You'll be able to see those kinds of network diagrams and also the list of connected nursing homes and the strength of connection to other nursing homes for any nursing home in the United States. And you can kind of check out where that work is. We've been aggressively pushing in several states for this to be, this is of course, like in some deep sense, like a second best solution. I mean, because we only have, for example, snapshots and a picture of the shared staff connectivity network for those workers, for whom we have who show up in these kind of smartphone panels. Turns out that's a pretty good measure of the overall network. But we're pushing in many states now also as well for a regulatory solution, where we basically kind of ask CMS to ask nursing homes to measure this shared staff network for using administrative methods, just kind of just literally collected from nursing homes and measure the shared staff. Okay. Thank you guys so much. I really appreciate your time, and I'm open for any questions. If anybody wants, you can either kind of write them in the chat, or go ahead and use the raise hand feature if you want. If you kind of want to ask, I'll stick around, and also I'll hopefully give you a few minutes for break between this and the next session. You can also kind of log off now. Thank you guys all so much.
Thank you, Dr. Chen. Thank you very much. I'm not sure about anyone else in the room, but there were definitely parts of that twisted my brain in knots.
Oh my gosh.
So we have several minutes for questions, either from the room or online. I think we have about 15 minutes in our schedule. So who's got the first question? Mr. Winters.
I've got an advantage because this is the third time I've heard this, and it's just starting to really sink in. And I'd first just want to thank you. We're working collectively, as you know. Dr. Chen came and gave us a presentation in the National Pandemic GIS Task Force. That's a collaboration between NSGIC and NAPSIG, ERISA, NACCHO, and ASTO. We're writing chapters that say, okay, when you're dealing with this sort of a thing, here are the spatial components that you need to consider. And that the playbook or the recommended practices are really geared to the policymakers and to those people outside of our industry that can benefit from the spatial data. The chapter on nursing home spread will be very, very short. It will be these recommendations. Don't try to repeat this. Don't hurt yourself. Watch this YouTube video, read this report, and take these recommendations, because you've just added a level of credibility to the analysis that is compelling. So for that, we thank you. But the question that I have is, how much of what you did was generally automated or supervised automation, from picking up the rooftop of the nursing home, to creating the convex hull, to analyzing those vectors? There's an awful lot of manual work if it wasn't really, really automated.
Yeah, that's a really good question. So so let me say, and this I think it will be useful and kind of unfortunately maybe painfully familiar to a lot of people who work with GIS data. There were two stages in which the kind of at least a lot of coding, and eventually we've been able to code all of this so that it's relatively automated, but that a lot of kind of painful coding and a little bit of hand checking of what we were doing was required. The first thing is these data are typically, unfortunately, largely duped, and I'll say why. And what I mean by duped is that you have to do a lot of cleaning to make sure that you even just eliminate kind of that you don't kind of overcount duplicate observations. And why is that? Well, because most of these data are presented like relatively real time, and most customers of these data actually want to know things like that. So for example, a typical use case of these data are something like either a store itself. So, like Amazon will ask, tell me kind of, with very little kind of, with very little lag time, like tell me kind of what footfall looks like in Whole Foods stores today. And then second, they're going to ask a question. Amazon will ask a question like, don't just tell me like how many people kind of walked through kind of Whole Foods today, and how much time did those people spend in Whole Foods, but what was the last grocery store that these people were at? So how much kind of shared foot traffic do I have with, for example, like Trader Joe's? Like how many people who walked into a Whole Foods today were in a Trader Joe's within the last week? They want to kind of know things like that. Because of that, typically the providers of these data try and provide these data as real time as possible. Okay, but many of their providers, many of the kind of upstream apps that provide them these data, a user may have like several of these apps, and they come in kind of staggered. Like you get this data from your weather app today, and then you also get it from from your real-time traffic app kind of tomorrow. And then both of those observations enter the data. So there's a lot of kind of cleaning to make sure that you know, you're getting high quality data and only kind of unduplicated data, which is not an emphasis of some of the providers, because of they instead kind of bias towards getting you the data as quickly as possible. Okay, so there's that. The geofence stuff, as you know, kind of you know, fortunately, actually, that's a little bit easier on this dimension, because you know, for example, kind of Microsoft, you know, there are several kind of projects by which you know, the Google geofences are not publicly available, but Microsoft has produced kind of rooftop geofences for a lot of the United States and has made that kind of publicly available. So, so one thing that you can do there is, instead of having to construct a lot of the geofences yourself, you can simply take what you think are rooftop pins, try and match those to rooftop geofences that are provided by Microsoft, and then only have to hand code the ones where either you don't have a rooftop pin, or you know, the Microsoft kind of provided rooftop geofences return kind of a value that just seems like it's just not building shaped. It's too big. It's too small. There's several places like in Manhattan where those Microsoft rooftop geofences, the AI, the kind of learning algorithm, those rooftops are typically not an individual building's rooftops, but are typically the entire block all fall into one kind of geofence. So, you know, there's a lot of settings where you have to kind of hand check that, but that's relatively that has part of that is automated, and then the part that's not automated you only have to do by hand once, because like fortunately rooftops don't move, so you can just kind of at least not in real time, so you can just kind of keep those standard things. Once you do that, you know, the automated filters for quality of the pings, snapping them to rooftops, and then from those data applying kind of filters to make sure you only have kind of intensive workers, and then kind of forming that connectivity network. All of that, you know, has been coded up now and is automated, and the website that I show you kind of regularly automatedly kind of updates those data. Let me just say, so Karen and a few people, there's a related question. Karen and a few people in the chat have asked what other occupations this could be applied to. So let me say I'll answer that question briefly in the negative. One thing that people had hopes that these data would be able to also kind of form is that, for example, you know, we have been able to kind of replicate this analysis with workers in meat packing plants, which was you know, which was another setting that tended to have like much higher than community level kind of COVID spread. One community that we haven't been able to replicate this for is prisons and jails. Largely because it turns out in prisons and jails, it's going to be inmate transfers that is the main that the kind of contact tracing was telling us was one of the main culprits in kind of COVID spread, and inmates usually aren't allowed to have cell phones or use smartphones, you know, within facilities. So we basically become blind to their movements because they're just, you know, the digital trace data doesn't work because they're not carrying around smart devices. Maybe that's obvious. Karen, does that answer your question? As I see kind of Jamie asking if you want to come off mute and talk a little bit.
Yeah, sure. Thank you. I'm more than anything just to say thank you so much, and echoing other people's comments. My mind is just blown by the, you know, thoughts and math that goes into all this and the analysis. So definitely appreciate that. But it kind of mimics somebody else's comments about, you know, restaurant workers, and, you know, I mean, it's such a complex web. So it's just fascinating to think about. So thank you so much.
Yeah, absolutely. Let me say one other thing. You know, we have a new project going with several other. We have a new project going with you know, to the degree that let's flip your question one more time and say, like, you know, can we actually you know, instead of just trying to use passively collective digital trace data, like there are several settings in which organizations actually have started to use this to try and actively collect digital trace data and use that. So for example, many police departments around the country now have started asking their officers to install an app on their smartphone that monitors, like, that basically says, hey, listen, we can attach GPS at something of a cost to every kind of police car, and many kind of municipalities and police departments do, so that they know where their kind of police vehicles are at any given point in time. But the other thing is, like, our officers are carrying smartphones, right? So why not utilize all of the digital trace data that's coming off of the smartphones? So several municipalities. So let me say, we've both helped municipalities look at the passively collective data to try and figure out, for example, something I'll tell you in a second, but also, like, help program up apps, and then the municipalities ask their kind of officers to download these apps onto their smartphones that then actively record both one, at any given moment, where is a police officer. So now we get a little bit of a better view of where do police officers spend their time, when on shift. And then second, like, we have other things, like, for example, all of these smartphones now contain accelerometers. So one passive benefit of some of this stuff is you can actually also say, like, hey, like, we can call an officer and check in with them if we see their smartphone has been completely immobile for some longer period of time, which may suggest that there's an issue, or you experience kind of a sudden fall. I know you've kind of all seen these kind of Apple commercials where, like, your Apple Watch now has kind of machine learning which detects when you may have taken kind of a tumble, or when you may have been in fault. There's a particular accelerometer kind of profile that shows up when you've been involved in a car accident, and if your phone or your Apple Watch kind of records that, in real time, now we can kind of send help. We've been applying that to those. So several police departments have asked us to help kind of do that, and that's giving us a better picture. Something that kind of police departments kind of, again, like, it's just very difficult to collect administratively, and have never known where do their officers spend time, like which neighborhoods are seeing a lot of kind of kind of officer hours. And then what that lets us flip that around to is measure things like for every person who lives in a particular city. So for example, for every resident who lives in Chicago, how often has that resident been, within the last year? How many times has that resident been within 50 meters of a police officer? So we can basically measure kind of across different neighborhoods and across different demographics, both exposure and exposure disparities to the provision of kind of law enforcement. And we have a new project. You can actually Google. Just go to my website, which is easy to find by just Googling Keith Chen, and you can see some of the output of that kind of research. So you can see kind of applications of a very related kind of set of tools and network analyses to other professions, and to address other questions as well, kind of closely related questions.
Any other questions in the room? I noticed there was a question in the chat, Jamie, about any privacy issues that were associated with the analysis.
Right. Shay, do you feel comfortable coming off mute and sharing your question?
So I work at Arizona State University, and again, I understand completely what you've done is anonymized and people aren't seeing it, but I also understand that doesn't mean you don't constantly have to justify and explain that to an incredible variety of your different audience. So how did you did you run into those issues, and how did you go about reassuring people so that you could continue with your work?
Yeah, so that's a really good question. So, we run things through kind of, several different institutions, IRB, both UCLA's and Yale's, and actually because of the CDC, kind of a little bit of a federal kind of IRB process. So I think your question has kind of like two components to it. So one is that actually, what we're doing here, because, for example, is largely unavailable to do in Europe, because GDPR. because of GDPR, that kind of upstream process by which kind of apps kind of anonymize these data and then aggregate them into pools, that industry largely doesn't operate in Europe. So, and also because you get very little, it's a little bit of a difference between opt-in and opt-out. Many of these apps, even the apps in Europe that do bother to try and collect these data and ask users permission to collect these data, so that these patterns can kind of be examined and looked at, basically constantly ask users to opt in, and if they ever don't click on that kind of opt in, then their entire history of their data is kind of removed from the panel. So definitely regulatory environments have kind of a picture of kind of a lot to do with whether or not these data are available. On the flip, so in Europe, this type of research is basically impossible, and these data exist to a smaller form. Again, like, actually in the US, like if you're an iOS device holder now, Apple has a policy by which the data is looks a lot more like GDPR's opt-in, and that hasn't completely collapsed this. Like there's still a lot of people who opt in to sharing these data, under promises of anonymization. On the flip side, like you go to Asia, and it's not even opt-in, it's just like everyone collects this data, and the carriers kind of openly sell it, and in fact, like, don't even anonymize it. So for example, in our data, we have kind of anonymized ID, we have kind of imputed home locations are often kind of, the exact latitude and longitude of each kind of geoping and marker is kind of, there's noise procedures which add imprecision to those measurements, within a radius of your home. So it helps even kind of protect kind of against any particular kind of de-anonymization kind of technologies. In Asia, like everything's off. Like you don't only know kind of things like smartphones locations. In Asia, these data sets contain the cell phone number of that user. They're advertising kind of hardware IDs, which let you connect the data, the location data that you get on their smartphones to every website that the person has ever visited, because that ID is shared across cookies. And you also typically know things like, for the smartphone number, what are the other cell phone numbers that are contained in this person's kind of contact list, and which ones of those are favorites. So you can form not just kind of like a movement panel, but you can also form kind of, in some sense, like a social network by asking, like, which other smartphones do they appear to call regularly. I mean, it's a totally different regulatory environment where you don't even have the opportunity to not share these data, like in Asia. I mean, it's all over the map. And this is to say that, like, we've had to explain this to regulators. We've had to explain this to IRBs. We've had, all of this data is basically contained on servers that are aggressively kind of even more, they're basically HIPAA compliant servers. Yeah, and the most direct thing is that we basically have a tremendous amount of scrutiny on the work, and kind of personal anonymity protections, and kind of non-identifiability kind of compliance procedures that are regularly audited. But yeah, it's tricky.
It's fantastic, Dr. Chen. We really appreciate your connection. A quick challenge to everyone in the room and online: we don't have to be experts in this. We just have to be expert in what we're good at, and that is finding the resources we need to get our work done. I watched a YouTube video after my son said, "You've got to see this." I went on the UCLA website, staff directory. I found Dr. Chen's email address. I invited him to talk, and now we're plugged into that community. So that's innovation that we can handle. We don't have to go and try to reproduce this, because there's armies of people who are super willing to share their help for the good of our missions. So we really appreciate your willingness there. And I'll be quiet, and Jonathan will take us home.
Thank you, Dr. Chen. And as I was listening to all that, I sort of had three reactions. The first one, like everyone else, was just wow. Okay, I mean, I think everybody had the same reaction. Number two, what else does this open the door to? This type of analysis or methodology? Just seems like it opens the door to so many other things, because this was about COVID transmission. Well, there's that approach of using the location data that's there and seeing that movement, and to me, there's just so many other things that's possible there. And thirdly, I'll always like to say, we take our data and do good. And Dr. Chen, I sincerely think you have taken the data and done something really good. And to borrow a phrase from one of our colleagues, carpe geo, Dr. Chen, carpe geo.